Hi, I'm Dr. Sandy Werner, and we're here in my emergency department where I've just been asked to assist with a lumbar puncture in a patient of fairly large body habitus. We've learned that ultrasound can be used to mark the spinous processes and identify the landmarks for lumbar puncture, and we're going to show you how that's done. For this demonstration, the patient is in the decubitus position. The procedure can also be done with the patient seated. However, the patient must be relatively comfortable because it's very important that they do not move between the marking of the skin and the actual lumbar puncture. The ultrasound machine is positioned so that the screen is easily visualized during the procedure. For this patient, we're using a low-frequency standard abdominal transducer in order to penetrate deeply enough to see the spinous processes. If the patient were of smaller body habitus, a high-frequency transducer might be appropriate. You will need a surgical marking pen or some other permanent marker that will not be removed by the sterile skin prep in order to do this procedure. Dr. Haggerty applies gel to the transducer and begins scanning in the transverse plane from the sacrum up the back. The ultrasound indicator is up so that the image on the screen corresponds to the patient's anatomy. The left side of the patient is seen on the left side of the screen. To confirm the placement of the transducer, depress the skin on the left side of the transducer and watch the corresponding tissue depression on the left side of the screen. The sacrum is seen as a bright white line with heavy shadowing behind. As the transducer is moved towards the head, a dark area is seen. This is the space between L5 and S1. As the transducer continues up the back, each spinous process is seen as a bright white line with heavy posterior shadowing, and the interspinous spaces are seen as areas of gray. With the transducer in the transverse plane, Dr. Haggerty is back at the sacrum, scanning slowly up. Bright white structure is seen, and that's the L5 spinous process. He identifies it and centers it on the screen. A mark is placed on the skin just above the transducer in the center of the transducer. It is very important that the spinous process is in the center of the screen when the mark is made on the skin in the center of the transducer, or the mark will be off center. The transducer is moved up the back and marks are made at each spinous process. Once the marks have been made, the dots are connected and the spinal line is now visible. Now that the spinal line has been marked, Dr. Haggerty turns the transducer into the sagittal or long axis plane. The indicator is towards the patient's feet. We're violating ultrasound conventions a little bit, but we want our ultrasound screen to conform to the patient's anatomy. And since the patient's head is to the right, we need the patient's head to the right side of the screen. And that's why we've put our indicator down towards the feet. To confirm that the transducer is properly placed, depress the skin at the bottom or indicator side of the transducer and watch the tissue deform on the left side of the ultrasound screen. Starting from the top of our spinal line, place the transducer in the sagittal plane along the spinal line. The processes will now appear on the ultrasound screen as bright white humps with black shadowing behind them. The interspaces are the gray areas in between. Place the interspace in the center of the transducer on the screen and place a mark next to the center of the transducer. It's very important that the interspace is in the center of the transducer when you make the mark on the skin, or the mark will be off center. Once you have marked the spaces, extend the lines across your spinal line, and you now have the location of each of the spaces between the lumbar vertebrae, and you can move on to perform your lumbar puncture. Where X marks the spot. As we've just seen, ultrasound can be very useful in identifying the spinous processes and the interspinous spaces in patients we need to LP who are of large body habitus or don't have easily palpated landmarks. Just remember, you may need a longer LP needle to actually perform the spinal puncture in these patients. There are two important things to keep in mind when you're doing the LP marking. The first is that the patient cannot move between the time of the marking and the time of the actual LP. And the second is that you must be careful to center the spinous processes and the interspinous spaces while you are making the marking. If you keep these two important concepts in mind, you'll have no difficulty marking the interspinous spaces and performing these LPs so that you don't have to send the patients off to fluoroscopy.